Today's video, we're going to return to sport testing for your athletes after major surgery like ACL reconstruction. Whoa, this guy's ready. What's up guys, this is Dan Pope from Fitness Pain Free. I'm a physical therapist and a strength coach. We've helped to make thousands of incredible clinicians through online courses, mentoring programs, and communities. In today's video, the goal is to make you 1% better. All right, return to sport testing after major surgery like ACL reconstruction is going to be very, very important. Unfortunately, and this research is going to vary based on the paper and the population, our return to sport rate after ACL reconstruction is only around 55%, and up to 20% or more of those folks will go into re-tear after the surgery. The thing is, we might be sending these folks back to sport too soon, so we want to have a nice battery of tests that we can use to assess whether or not your athlete is ready to return to sport. We have some research by Dowd et al. In 2024, and this was in patients after ACL reconstruction. What they found is that they passed the battery of tests, they had a 36% reduction in re-injury rate. So in today's video, we're going to go over the exact tests they use in this study so you can apply it to your patients. And here's the thing, the large majority of return to sport testing is going to be found in the ACL reconstruction literature. But I use these same tests with other knee pathologies. Let's say I have a meniscus repair, and I also use it for other pathologies in different joints. Let's say FAI surgery for the hip, PAO for the hip, or Achilles repair in the ankle. And your battery of tests should include several things. Number one is going to be strength testing. I'll leave a link in the description if you haven't seen my video on strength testing first. The second is going to be a battery of hopping tests. This is going to be both for how far you can jump, where you compare to the contralateral limb, as well as the quality of the jump, which we'll go over in a minute. So essentially, they can't jump poorly or compensate by moving through another joint. We also want to make sure that patients pass patient-reported outcome measures, as well as psychological readiness questionnaires. The video is not about these though, but I will leave a link in the description if you guys want to check out my favorites.
Hey there, sorry to interrupt, but I've got something cool. It's an evidence-based exercise selection cheat sheet after ACL reconstruction. Sometimes it's a little bit scary working with patients after ACL reconstruction. Obviously, you don't want to hurt them, and the exercises that we choose matter. So I created a cheat sheet to help you out. It goes over which movements have the most strain on the ACL graft and how to dose those exercises from low to high. We use the evidence to guide us so you can make the right decision for your patient after ACL reconstruction. We'll also tackle that age-old question of whether or not you should be using open kinetic chain knee extensions with your patients early on after ACL reconstruction. This cheat sheet is 100% free. I'll leave a link in the show notes in the description below. Go ahead and click on that and get to learning. Now, back to your video.
All right, single-legged hop test. We're gonna have Jacob here start with his hands on his hips. We're balancing on one leg, doesn't really matter where you start. We're gonna do both sides. And from here, my instructions are have Jacob jump as far as he can, but when he lands, he can't lose his balance or hop around at all right? So go ahead and give it a jump. Good, perfect. And what we do is we measure from the toe to the heel. I'd say for Jacob there, he probably didn't stick the landing, so I'd make him do it again. Yeah, let's go ahead and give it another shot. This time, just make sure you stick it. Yep, good, perfect. And then from here, you measure from the toe at the start to the heel, and that would be your measurement. And then what we do is we compare your involved side to the uninvolved side, and the goal is to have 90% or greater symmetry to pass the test. Now, a couple notes on movement quality. Your movement quality for these hop tests, not as important as one of the ones we're gonna go over in a minute, but I do think it's important that you assess movement quality on all your jumps and make sure it looks okay. There's a few big compensations you may notice. There's something you wanna try to correct before you return your athlete back to sport, right? Let's say you have an athlete that they have 100% symmetry between sides, but one athlete is using a very large hip strategy as opposed to a knee strategy. That's not good. Let's have you turn to the side, Jacob, and show me a landing strategy when you're moving mostly through the hip and only a little bit through the knee. Yep, just like that. Now show me a strategy where you're equally bending through the hip and the knee. Good, excellent. And here's the thing. If you're kind of curious, if your athlete is doing a good job, just look at both sides. I generally will take a video from the side, left side versus the right side, do a freeze frame, and just compare how much bend you have either one, okay? We're looking to have symmetry between sides, again, making sure that knee is moving appropriately. The second thing we don't want to see is dynamic valgus. So let's have you face the camera here, bounce on one side, and this presents in a variety of ways. So A, you can have the knee coming in a bunch when you're jumping, or you can have the toe facing out a decent amount while the knee is straight ahead. Largely, we're just trying to make sure that the knee, as well as the foot, are facing the right direction, okay? The other way we can compensate with a view from the front is moving through the hip. So when we land and we absorb force, as opposed to doing this through the knee, we can do this through the hip in the frontal plane. So if you drop your hip aggressively, just like Jacob is showing, you might not be moving through the knee the way we want to. One more compensation you see from time to time, although this is going to be more common in patients after, let's say, some sort of hip FAI surgery, is going to be an abduction lurch, where they're starting to lean to the side when they land. So all of these are subpar, and if you're noticing a lot doing your typical physical therapy that your athletes are doing this, obviously you want to correct this. And if you're seeing it during your jump testing, I would try to make sure that you clean this up before you progress your athletes back to their sport. Single-legged triple jump. Again, we're going to have Jacob bouncing on one leg. The starting point is going to be right where his toe is at. That's where we're going to measure from. And from here, he's going to do 3 jumps, one after the other, and stick the third one without losing his balance. Go ahead and jump for me, Jacob. 2, 3, good, and make sure you're sticking that landing. And from here, we just measure the starting point at his toe, all the way up to the heel, compare left to right. Just like with a single-legged jump, we're gonna make sure there's no weird movement compensations. One really stupid test you probably shouldn't do with your patients is exactly what Jacob's doing right here. But what you should do is like the video and subscribe to the channel. Triple crossover hop for distance. So Jacob's gonna line up here at the end of a line. It's gonna be 3 jumps. Every time he jumps, he goes over top the line. His jump's gonna start medial, then lateral, then medial. He's gonna stick his landing. You measure the distance between the toe where he starts and the heel where he lands without losing his balance. You ready for this, Jacob? Go for it. Medial, lateral. Yep, stick that landing. Woo, good job. Box drop, vertical jump. So largely, when we do this drill, we're assessing for quality, left to right. So all those things we talked about before, making sure there's no compensation at the hip, making sure we're bending well through the knee, no dynamic valgus. That's what we're looking for in this assessment. The idea behind it is that if you have a high enough box, this is actually higher than some athletes can jump on their own. I'm not trying to pick on Jacob here. He can definitely dunk, so his box would need to be higher. Just for demonstration purposes, we'll keep this. But the idea is you have a high enough box, when he lands, this is gonna be a very, very difficult height to control because normally he can't get up to that height on his own. So the challenge of the movement is so high that if he was going to break down and compensate, it would happen during a movement like this, right? And basically what we're going to do is have Jacob step off the box, and then as soon as he lands, immediately jump up in the air, land, and stick that landing again. We're gonna video from the front, we're gonna video from this side, and just make sure we're not getting any compensation. You go ahead and show this for us, Jacob. Big jump, soft landing, nice, good work, and that's it. Modified T-test, this is an agility test you have your athletes do. Combines a variety of different running strategies. So you have running forward, backpedaling, and shuffling. And essentially we start on one side of the T-test, run this through full speed, time it. We go to the other side, run at full speed, time it. We compare left to right. We're looking for 90% symmetry between sides. All right, Jacob, let's have you run through this. Running forward, yep, shuffle, 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 around the cone, back pedal, shuffle, yep, going straight across, good, and back pedal, back pedal, back pedal, excellent, very good. Now guys, we made this smaller just for demo purposes, but normally you have 15 feet between cones, and then just again, make sure you're measuring side to side, we're looking for 90% symmetry. Now, movement quality is most likely going to be important when your athletes are doing change of direction drills. This just was not included in the Dowd study we mentioned previously. You will see a few studies that do running and then cutting, and they will fail you based on having abnormal compensation patterns. I just want to go over these because when you are doing your change of direction drills with your patients, you want to be on the lookout for these, you want to correct them over the course of time so that when it comes to testing, they do it well, and ultimately when they're playing, they do it well, right? So the first of which is going to be not loading the surgical side. Let's say Jacob had right side ACL reconstruction, he's shuffling to the left, and when he stops on his left side, he may compensate by going over to his left. You mind showing me that, Jacob? Yep. So he may not plant well and get that way in the inside leg. Normally what we'd like to see is that when you change directions, you load up the inside, and you're in a powerful position to produce force the opposite direction, right? The other thing you may see is a torso sway. So largely athletes go and they cut, and they sway to the side before they come back. Can you show me that there, Jacob? Good, sway, and come right back. So ideally, again, we want to land in a good position, be powerful, move the opposite direction. Another common thing you'll see, and this is usually when folks start doing change of direction drills, is they'll just stop. When they're trying to change directions, they'll just freeze in place and then go back. This is largely because they don't trust that knee or the ankle, whatever else you're returning back to sport from. But show me one of those, Jacob. Just pause, good, and they come right back. Yep. So we want to make sure over the course of time we're correcting these things. The other thing we want to make sure we're not doing is having any sort of dynamic valgus. Now, this is not as obvious as what you'll see when folks are jumping and laying on one leg, but you may see some of it, all right? And largely, you might not see the knee cutting in a lot, but you may see the foot is spinning out and the knee is straight ahead. So largely, what we want to see is when we change directions, if the toe is facing straight ahead, so is the knee, right? The foot is facing out some, the knee just follows, and same thing goes for the inside leg as well. All right, Jacob, so I'm gonna have you do a shuffle and then pause, and we'll show some dynamic valgus you might see with your patients. Let's go ahead and shuffle and then pause. Load up the inside leg. Sometimes what you'll see is this foot is spinning out towards me, but the knee is still ahead, right? And then let's fix this one again. And sometimes you see the same thing over here. So this foot is out, yep, and this knee is facing in. So like I said previously, we're just trying to make sure the knee and the toes are lined up when your athletes are changing direction. We're not noticing any offloading from left to right or right to left. So this study by Dowd in 2024, when they did this return to sport battery testing at the 10-month mark, which is a pretty long distance out from ACL reconstruction, only 27% of these patients actually passed the battery, right? When they tested again at the 12.5 month, only 73% of these folks ended up passing, right? So that's actually a little tough to hear because you might be expecting at the 9-month mark as a patient, get right back to sport. Turns out you're still quite a bit weak and you're not passing these tests. It's probably good to delay things quite a bit, right? Let's say your patient didn't pass these tests. We still gotta work on some good old plyometrics to improve their movement. I have a link for you in the corner, or go over my favorite plyometric progressions for your patients after major surgery, like ACL reconstruction. Click on that link and I'll see you in that video.